Don't be afraid, we speak in English. Unfortunately, today I am the only speaker speaking English, but for me it's absolutely impossible to try. Thank you for the invitation. I think it could be a very good opportunity to focus the use of collagenase not only in normal and easy cases, but also in advanced cases. And which are the difficult cases? Some of these divisions are overcome because all you know that also in Europe now the double-level multi-chord has been approved. But once is considered off-label, we have to consider the joint stiffness. The problem of Dupuytren mainly is the stiffness of the PIP, mostly of the fifth finger, and we have to treat maybe surgical or limitation point of view like all other stiffness. So it's not a problem of the Dupuytren. We have to consider the Dupuytren as the disease and the problem created by Dupuytren as another problem to be treated, maybe sometimes in the same times, maybe in 2 different times, with the appropriate technique. The stage 4, you know that the international classification are moving from tubular classification to degrees classification, but mainly we can say the worst cases, were the 4th. And some question about the first web and more about recurrences. So just a look, this is a double level, this is a multi-chord. This is a problem of stiffness. You know that we have the release of Dupuytren, we have still now the stiffness of PIP, and we have to treat from the rehabilitation point of view. Sometimes we have performed a TATA in the second time. The first web, Larry Hurst said in the first time that the first web are not indicated to be treated by collagenase, but this idea was overcome and is overcome, and he presented a very interesting paper some years ago focused on the thumb and the first web, who can be opened very efficacy. Question mark on recurrences. Surgeon using the collagenase receive many questions by patients who ask for the treatment and not for surgery. And starting last 5 years, we began, like Stephen and many others, in treating the recurrences with good result comparing to the starting point. So this is, these are some of the best and more recent paper on the use of the double level, of the multiple level and multiple ray, and we have presented this paper and published it of Italian newspaper of health surgery. Is Italian, but the paper is in English. So what we is not focused. I don't know if it's the no, it was my eyes. Okay, so we were able to analyze 597 patients who has enough follow-up to be evaluated, and we distinguish in the group A and group B. In group A we treat only 1 joint, in group B we treat 2 joints, and you can realize that the group B is wider than the first. And we can begin to look to the result. We can say that distinguishing from moderate and severe, we never treat a patient with less than 20 degrees of inflation, both in MPA joint and PIP joint. So the advantage, the final result was good, both good in moderate and in severe. And here we have a comparison between the The blue one is the totally efficacy and the moderate case and severe case. And we analyze 3 elements. One is the reaching of the extension from 0 to 5 degrees. This belongs to the old protocol of collagenesis, not an international scientific evaluation. All of us has abandoned now, but we have analyzed according to the protocol, and so realized that there is the difference for moderate case there is no difference, for severe case there is a difference 10% of difference if we treat 2 joints at the same time. We analyzed the possibility to have an improvement of at least 50%, and we were able to reach in 100% with moderate, and if we move to 2 joints, the level decrease, but 50% is not enough to evaluate a result. So maybe this last slide is more interesting, the percentage of improvement from the pre and post of time. So realize that the improvement in several cases with 2 joints is not so good like moderate and with 1 joint, but it depends from the level of the gravity of the pathology. So, step by step, what has been changed from 0.x protocol to clinical use now? The level of infiltration. You used to put a black dot on the skin to remember when we have injected the drug, and it's divided in many dots, and we overcome the level of the line considered of limits during the 0.x protocol. And we use to make infiltration also in the web between long finger. As for the dose of drug, we can move between the use of all the drug you have in the vial and the use of the drug, according to the drug you need. This is, I think, a very relevant aspect for us, because we began according to Badavent and last with the local anesthesia, but we move immediately with sedation. We think that sedation is very important, not only for the pain, because usually they say that the Italian as are in south, so they are more painful than people coming from north. And in Italy there is a difference from Milan to Naples to Sicily. But this is not the problem. The problem is not only the pain, the problem is the contraction of the muscle. So if we are able to stop the contraction of the muscle, the flexor, we avoid to damage the tendon, and we can obtain a reduction also of the stiffness. And we will show you the results. So our protocol now is the block of median ulnar net at the wrist and sedation in 100% of patients. The technical construction is well described by the very fast and all authors. So this is the destruction of PAP, and this is an aspect I believe in very much, because we have to obtain the destruction of the aponeurosis, a destruction of the palm. It's not so easy, because in the middle of the palm there are no articulation. So you have to begin with destruction of the palm, and you are able to obtain a despairing of the nodules and of the contractor. It is really different from the 0.x. You have to and the starting point. You have to obtain the rupture and nothing else. With this kind of technique, we can obtain the hyperextension of the long finger, and sometimes you have no evidence of the disease in the palm. Post-op time, I think, is very relevant. All the times we speak about rehabilitation, about sleeps, there was divided between people who believe in and people who don't believe in. People having really therapists, people having no therapists. I think in my unit I have 37 hand therapists dedicated only to hand rehabilitation. And this gives me the possibility to perform all what I need for post-op time. This is not a post-op time of Dupuytren, because there is no operation. This is a post-op time of the stiffness created by Dupuytren. So I think that if you are able to manage a good quality of post-operative time, the advantage and the final result are absolutely evident. So, just to have a look to some case, we have two ray and the first web. You can obtain the opening of the web, the distension of the finger. This is a case of the stiffness of the pivot fifth, and look at the distension of the necrosis. This is a very similar case with 3 fingers involved in distension of the necrosis and a better extension of the PRP joint. In this case, we have a rupture of the skin. Once was quite regular, because many times we have maybe that the problem was that we were obliged by the protocol to put the drug in the same place, not to be distributed around the pathology. And the second, I think, is the technical traction. If you make tension only on one articulation, maybe over only one joint, maybe that the skin is unable to move independently by the pathology. If you are more selected, starting from the palm, isolate the MP joint, isolate the PIP joint, the problem of the scar becomes secondary. But this is a sort of enzymatic open palm, and you obtain a good healing, usually in less than 10 days, and the patient moves exactly like in the open palm. Here we have a case that, like the other one. This is a very interesting case with a complete opening of the hand. Finally, I want to show step by step some cases with multiple level and multiple ray with the final result. So I think that we have to think about the use of collagenase like an opportunity, a good opportunity. In my unit, all patients are treated with collagenase. We operate less than 10 patients a year. All of them are recurrences of previous operation for stiffness or retraction of scar and so on. And maybe that in very difficult case you can have 2 possibilities. Or you can use 2 vials, or independent by the dose of the drug. If the problem is the stiffness remaining at the end of the treatment, you can treat in the second time the patient 1, 2, or 3 years later, independent by the recurrences. All of you remember that when the recordotomy was proposed like an approach to nephrine surgery. Of course, no patient want to be operated anymore the second time, and all of us have used 2, 3 more times or more than they need. Maybe also that in collagenase you can have a first release, and if you have to complete in one article, in one joint or in one finger the result, you can repeat some year later. Thank you very much.
presentazione bella.
Fantastico,
thank you.
parlavo italiano.
That's all I can talk in Italian, so it probably was not correct. So, are there any questions from the audience to Giorgio? So, if not, so yes, okay, starting.
Do you use the full volume of collagenase in the vial?
I use all the volume of the drug, not all the volume of the water, of the diluent.
No, of course.
Yeah. 0.9.
Yeah. So you still dilute the 0.39 or 0.40, yes. And then when you withdraw the active pharmaceutical component out of the vial, you pull out everything.
Exactly.
Okay.
So that when we say that we have to use the drug in different points, is that we don't use only one place of injection. Yeah. We dilute, we distribute, but we have not to decrease the efficacy of the drug.
So you skipped this division, injecting 0.20 in PIP joints and 0.25 in MP joints.
No, I don't know.
So you use
anymore.
Okay, the same.
I
do the same.
I think that every time we do a protocol, we have to attend it, but in the second times it becomes a sort of obligation to maintain what is not necessary to maintain.
Thank you.
I think in Germany the use in multiple levels and multiple joints, the use of collagenase is an off-label use. It's officially only approved for one joint. How is it in Italy? It's the same, or is it no problem?
Oh, I am a surgeon, so when I began 10 years ago, I was absolutely sure this was a disaster, because I prefer other techniques. So sometimes it's been difficult for me to understand the difference. So what I was able to focus is that there is a sort of clinical efficacy, so the off-label in the amount of the drug on the treatment of Ray is a clinical off-label, that to say that your responsibility to use. And this was I have done starting from 8 years. And I was able to sleep the same in the night, but we have done. The site of injection, I think it's different, because it doesn't interfere with the amount of the drug. And what we think is that putting the same drug in the same place could be more dangerous than to distribute. The problem is that, as Stephen can say, that it depends from the amount of the pathology. So sometimes you have a very strong tissue, and so you have to distribute, but not to diffuse too much, otherwise you decrease the efficacy. But I think that it's off-label because in Italian we say bugiardino. In the paper connected with the grass, with the drug, the technique is described in this way. But I think that your responsibility is according to the amount and the multi-ray, and now the EMA is provided, so it's not a problem.
Okay, thank you very much. I think we have to go on. Thank you, Giorgio, and we go now to